our theme of the month, our vocational presentation by Damali. This month we've done,
First.
yeah, you're first. So this month we've done mostly Rotarians. Well, today is Rotarians in the medical field, but almost all the things that we are doing this month are medical related. So it is going to be very, very nice. So we're going to start, and normally I do the introduction of the guest, but because of her vocation, I want her to introduce herself. Damali, the floor is yours.
Oh my goodness. I actually thought I was going to be second.
You
Not a
sent out the
problem.
agenda.
Isn't okay? All right. I just feel like I talked so much reading all the books. I mean, of the books, reading all the. It felt like I was reading a book. The messages, not a problem, not a problem. So, vocational discussion. So, as you all know, my primary vocation is nursing. I have been a nurse for, Lord, I think we're going on 2004. Let's say almost 17 years. And though I have made a transition to education about more than a year ago, almost a year and a half ago, I still say that I am a nurse because I am a specialized nurse, an advanced practice nurse with a specialty, two specialties in management and one in education. So I kind of straddle multiple areas of expertise. And so my recent endeavor into the field of education, which is very surprising because my mother had always told me, God, if you're going to be a teacher, you should be a teacher. And I've always denied that. And look where I come, full circle in education. So what I am currently busy doing, if for those of you who are not aware, I am the change manager at the NEPA, responsible for the nursing programs, which we actually launched today, the new nursing programs in collaboration with Chamberlain University and AUC. That process has taken over a year, not only of preparing the new program, but also phasing out the old programs, which has been a very learning and trying and challenging period for me, but it was really, really great. My master's degree program at Walden really prepared me for my current position, so I'm really enthusiastic about that. Just as enthusiastic as I am about bedside care, but I believe that my contribution to our healthcare, our local healthcare system, is greatly impacted by training nurses, training the future nursing generation with what I do, and so I can still have a close affinity to nursing, but now using my expertise in a different fashion. What else can I say? Um, I think nursing and education has a lot of similarities in that nurses also have a task to educate patients, and so I'm transferring that knowledge to what I currently do. Um, there is it's a very respected profession to be an educator, and it also requires a large amount of care and empathy to be able to get somebody engaged to actually take up the knowledge that you're trying to to share with them so that they can make it their own and move forward with that in their profession. So yeah, all in all, what more can I say about that? I think it's like quite a bit. It would help if I would get some questions and I would be happy to answer those.
What made you go into the medical field?
What made me go into the medical field? I from a very young age have always been the one taking care of people, animals. It started particularly with animals. I was always the one taking care of the dogs and the cats. I was always the one giving them their baths and their medications. From a young age, I could give a dog or a cat a tablet. I actually wanted to become a veterinarian, but and I was up in the entire way through primary school. I was going to be a veterinarian. Dr. T, who had the vet clinic next to St.Martin School, told me when I was 12, I would be allowed to come and do volunteer work with his in his kennel. But then I read a book when I was 12 about midwifery, and then I decided throughout high school I was going to be a midwife. And then I was 17 when I went to the Netherlands and didn't get into midwifery school. And instead, I did nursing until I got in. And then I found that I really have a knack for nursing. And so, kind of by accident, I ended up in nursing and found that I was quite good at it and quite fond of it. So, as you could see, there's a trend with caring for, taking care of people, animals, So kind of, I would guess to say I was born with it.
Any other questions for Damali?
Is there a possibility about you go later on in life wanting to be a doctor? Do you see yourself?
No, at my age, it is not. It doesn't make sense. I think, and that's the unfortunate part. I think if I had, and I think that's typical of women, if I had the confidence in my own ability that I have now, if I had that in my 20s, I would have definitely gone and done medicine. Trust me, it would have been a piece of cake. Now that knowing what I know now, medicine is really not that challenging. I mean, it is. No, let me not say that. It's difficult, but you can do it. I know I have the brains for it now. I believe and trust in my own cognitive ability, and it's a lot of hard work, which I definitely have. I'm definitely dedicated. When I sink my teeth into something, I get the job done. Um, so yeah, but that is a gone. That's passe. I have no desire to put myself through that torture, to only at the end of the journey to come out and only be able to be you can't do anything. Trust me. You, no, it doesn't make sense. If I was in my 20s and I would have finished in my late 20s, maybe early 30s, it would have made more sense because then you can really specialize, become a surgeon, become a gynecologist. They would, yeah, it doesn't make sense now. But smart enough to be a doctor, but chose to be a nurse. And you need very intelligent people at the bedside as well, taking care of patients 24/7. So the nurse is just as important.
Are you a LPN, a registered LPN
Me?
license registered nurse?
Me?
Yeah,
I
I'm
am
sure.
I am I am a master's prepared nurse. I had a batch I have actually had an associate's degree, I have a bachelor's degree, I have a master's degree, and I have a postmaster's.
So I know there are different types of nurses. So
Correct.
you are all those different types of nurses in one.
Yeah, so nursing, you're right, nursing has different levels, and it
Mhm.
depends with your academic background, so the foundation that you have. I went to Harvard from MPC, and then I went to Holland and did my bachelor's program. I encountered some difficulty during that program, and they made an exception for me because I guess with the whole culture change and being alone and language barriers and all of that, that impacted my performance. They saw that I could hack it theoretically, but I needed more time practically. So I was advised to do like an accelerated associates program, which I did. I think I did that in like a year and change. And then I was allowed to come back to the bachelor's program, and I finished that in a year. So in total, I did my bachelor's degree in 5 years with a gap in which I got my associates, which is an unusual trajectory. And then I specialized after that in high care nursing. And then I came to St. Martin, and then I decided to pursue that dream, that long dream that I had many years ago, but I didn't have the confidence to do it. And so I decided to get my master's degree, but I don't have a specialty in direct patient care. So I am not a nurse practitioner. I have an advanced practice degree in management, leadership and management. And then I recently did a postmaster's program for nursing education. So both of those master's specialties help me in my current profession.
Damali, do you miss the practical side of
I
nursing?
do, I do, I do. I worked in the ER, so that's like, super, super exciting. And I used to know everything that was going on, and I feel so out of the loop right now. And I miss, hearing the ambulance coming in, and I miss the gunshots and the machete chops. And
Oh, geez. Would you ever return?
I don't think so. You know what? I can't believe I'm actually saying this. And had I said this in July of 2019, I would have said, y'all crazy. There's no way I would ever leave the bedside. But I think with my current um I think my current job challenges me in ways that I wasn't feeling I was getting the challenge anymore at the bedside. So when I was in the COVID team earlier last year, when they had the
I was
lockdown
gonna
measures,
say you came back for a
I
little
did come
bit.
back. I did come back, and I did love working with patients. So I do like working with patients directly, but when I was not working with the patients, I felt I was bored. I was so bored. I was so bored. I
I
think I
had to
think
Mhm.
I was so bored because I enjoy working with patients, but when we were not actively busy with patients, I found myself getting frustrated because I didn't have the final say anymore, or I never had the final say when I was there. But now I have the final say where I'm at, and it's just nice to be in charge. Yeah.
Would you
Can
be,
I ask my question?
would you,
Go.
sorry, just 1 minute. I have to congratulate you for Anipa for starting the program.
Yeah.
Yes.
Oh, I'm so.
Um, I could imagine how exciting it is.
It
And
is.
one last question. You're spearheading the management part of it, so you won't be dealing directly, um, going with the nurses into the medical center, making sure they um, are prepared instructionally for the practical part. Would you be doing that, or somebody else will be doing that part? You just managing the program?
Yeah, so I am currently managing the program. That's 1 minute. I have my camera moving all kind of funny ways. I have it in my lap and then the cat. Okay, sorry. Yes. You are correct. I am more administrative when it comes to the nursing program. I do have the qualification to teach, but we do have sufficient faculty at this time to really do the true teaching in the classroom setting. How our program is set up, similarly to the previous program, our teachers don't go with the students to the clinical internship sites, so to the clinical experience sites. So you won't see any of the nursing faculty from NEPA going into the hospital or into the White and Yellow Cross Foundation to guide the students. They have preceptors, or not preceptors, they have nurses at those facilities who take charge of that, but they work closely together with us to ensure that the students meet the outcomes of the program.
You want to listen?
Suki, you had a question.
Okay.
Yes. Damali,
Yes, sir.
pandemic just started. How are your feelings? Should you have been in the hospital, or thank God I'm not there anymore?
I felt terribly guilty that I was not in the hospital. I felt
I expect
horrible. I
I
felt horrible,
expected that.
which is why I went back. The minute I heard, I was like, before they even had the call on the radio, because they actually made a call on the radio for people to come and assist. Before they even did that, I had reached out, like, look, now, if y'all need me, I'm coming, I'm ready. Just, yeah, I felt horrible. I felt totally, totally horrible. Very
My
guilty.
second question would be, it's of two things. Your best experience as a ER and
Mhm.
your worst experience as a ER dealing with patients.
My best experience as
Like, you still remember that patient who you treated and he's so nice and he is calling you once in a year, thanking you, whatever it is, the
oh, well,
best one and the worst one.
I'm thinking, and I
You don't
can't.
have to take their names.
No, well, I honestly can't remember. I can't really remember one incident because I've had many good ones and I've had many bad ones. Not no, I've had experiences what other people would consider horrible, but to me that just was part of the job.
Challenging ones.
You
That's
know,
how you
and
describe the bad ones. They're challenging.
even the most, and I really can't think of anything. I pretty much roll with the punches, and I really don't take anything personally. So where one person might consider, my mother was once at the ER and she had nothing. She was not there as a patient. She was just waiting to pick me up, and some people were getting on outside, and she was like, "How are you putting up with this?" I was like, "Yo, this is just part of the job." Um,
No, just
I
give us
can't.
an experience, like how it was. One of the good ones. Okay, I don't say the best one, but one of the good ones, that you had so many good ones and so many bad ones. Just
My
give us an experience.
my favorite experience. I'll tell you what made me always feel good. What always made me feel good and validated that I was doing the right thing if somebody would approach me after the fact and like on the street or in the supermarket and come up to me and say, "You remember me? You were so nice and you helped me so well and I understood, and because of you, XYZ, XYZ." And I totally forgot. I don't remember them. I don't remember them at all. because I guess me, because I feel really strong about patient privacy and anonymity and all that. If I see a patient that I do recognize, I never approach them. If they come to me and they start talking about the encounter, then we had discussed it. But I would never say, "And how was your?" No, I don't do that. But that always made me feel good. When they say, "Yeah, do you remember me?" I say, "I don't remember you, but did you have a good experience?" Okay. So, and then they would approach my mother too, because St. Martin is small. In the Netherlands, I never encountered a patient outside of the hospital, ever, never. But here, it's such a short distance between, your work and your personal life is so close, and they let you know. So, and I always had good feedback. Always had good feedback. When I think about the negative parts, it's more just people in their worst moments and not behaving their best. But from my professional standpoint, I can say this person is not talking to me directly. I'm just in front of them. It could have been anybody. And you just let it roll off your back. And maybe I can do that a little easier than some of my colleagues. So yeah. Yeah, losing a baby was a horrible experience. CPR of an infant, and that the infant died. That I remember having shed tears about that. I remember shedding tears about that. Or a spouse who is dying, and then the spouse who's going to be left behind, who's going to be the surviving spouse, tells the dying spouse, "I will never fall in love again. I will never marry nobody else." And that's just, that's horrible. That's hard. I also remember when I got my bachelor's degree, I was working in a hospital in Amsterdam, and there was a 23 or 24-year-old girl with a brain tumor, and she had been told that she had an inoperable brain tumor, and I felt really close to that patient. And I remember leaving her. I stayed over my shift, and I left, and I was walking out, and I got a phone call, and my classmate told me that I passed my exam and that we were going to graduate. And I just burst out crying because I was like, "How dare you call me and tell me this right now? Somebody's dying, don't you know?" Yeah.
Well, good to
So I do
hear.
similar things. Yeah. Nursing is the bomb.
You sound like you're missing it a little bit.
Yeah.
I do. But I've moved on. I think when you want to advance in your career, you need to move forward and you let go certain things. I mean, I think if they'll tell me now, if it was possible, if we had like a 9-day week, I would work 2 days in a hospital, because I can't. I work more now than I did in the hospital. Hard to believe, and I did a lot of overtime. So if I wasn't in this meeting now, I'd be working. So yeah, that's it. The nurse educator, straddling two worlds.
Does anybody have any other questions?
I just want to tell Damali congratulations, and I'm sure you're following the same step as your cousin uncle, Mr. Antonio Pantaflet. Congrats.
Thank you so much. Thank you.
Okay.
My cousin.
All right.
Thank you so much, Damali, and congratulations. We wish you the best in your program.
Thank you.
Yeah, thank you so much. I think that was inspiring to a lot of us.
President, I would like to give my experience.
Go ahead.
Sure.
The endurance test of a nurse. When I was hospitalized for my COVID, and I remember it was my 16th or 18th day, but all of a sudden at 5 p.m., a nurse rushes to my bed and she just unplugs the oximeter on my bed and takes it away. So I really got frustrated, because you see, half knowledge is also a bad knowledge. So like, I was thinking my oxygen is out. I started to curse her left and right, and all the other medical people came in. I shouted, I was screaming. My condition was bad. Like, every small thing was making me frustrated. So I was cursing her and all, not knowing anything. So the physiotherapist who was there for me, he came in and then he cooled me down and he made me walk. So I was telling him, he made me walk in the unit, which is only might be 20 feet or 25 feet. So while I was walking, that was after an hour. While I was walking, I saw that nurse, and she was trying to help a COVID patient who was nearly going to die.
Mhm.
At that moment, I realized, and I just went and I held her hand and I said sorry to her. And I didn't see her face because they were all in masks. Now the best situation comes when I'm out of COVID, and after a week, I went to visit all the nurses and doctors to hug them and thank them for what they have done to me. This was the first woman who came and jumped on me and said, "You remember me?" I said, "I vaguely remember because you all were covered." She said, "I was the one who you were cursing inside there, but I'm really glad that you are out. We take all these beatings, we take all the curses, just make sure that the patients get better."
Oh, thank
Yep.
you. Wait, the
That was my experience, and I
come down
really,
here.
it is
Oh,
in my heart
you can see you.
that.
It's
Thank
a,
you, Cookie.
I really
So
think
always I've respected nurses and doctors, but my respect for them have gone even much higher now.
And you always see that when some people just don't understand what it is
Yeah.
the job entails, but once you
She did
become
not even utter a return bad word to me,
yeah,
like how
yeah.
much I was cursing her. She did not respond in any negative way.
Mm-hmm.
She said, take it easy, take it easy. So that was the only response I got from her.
Yeah.
But after when she came up and hugged me, like it was tears in my eyes.
Yeah.
I hope you said sorry to her.
Yeah.
He did.
I did.
He did.
I did the same moment after an hour when she was treating, like they were really putting through a lot of things on him, and he could not even get up. He could not even urinate. That patient was really terrible. So when I saw that, it was really like, what did I do absent-mindedly? And how did I scream and all everything came in front of my eyes.
Yeah.
Thank you for that story, Cookie.
Yeah.
Our next presenter today is Sophie Leedee. Sophie, we would like a little introduction of yourself and tell us about how you got into this field and why you love it so much.
So I am one of the current pharmacists at Cahill Pharmacy, which serves the St.Martin Medical Center. I say one of the pharmacists because I have one colleague pharmacist, Andwele, who's technically the managing director. So he's technically my boss. But we handle a lot of things quite equally because up until I showed up, he was all managing everything himself, and the St. Martin Medical Center has a history of, since its opening, only having one pharmacist ever, like at a time. So when I arrived, it was the first time that they had two pharmacists on staff at the same time on a permanent basis. Before coming to the St. Martin Medical Center, I was a pharmacist in the UK for roughly 8 years. I studied in the UK, trained in the UK, and qualified and practiced in both community and hospital settings for a total of 8 years, and then decided to come here. I didn't want to come right away. After a lot of people were like, "Oh, you're a pharmacist now. Why don't you just come home?" I didn't think that would be beneficial to anybody because a lot of what you learn as a pharmacist is what you do while you're working. So I said, if I come home right away after school, I'll be useless to myself, to the doctors, to the patients. I needed to get some experience under my belt first. And then when I felt ready is when I came home. So been at the SMMC for just over a year. The reason I came into pharmacy was actually initially I wanted to be a doctor. And then you'll hear this from a lot of pharmacists. I realized I don't like touching people. Because when you see what doctors have to deal with and all the stuff that they have to do, I was like, I liked all the medical side of it, all the problem solving, knowing about the body and everything. But when it actually came to having to touch people and deal with all the mess and all of that, I was like, that's not for me. So I thought the next best thing would be a pharmacist because I think nurses have it even worse. So I was like, that's completely out of I'm not doing that. And what I did initially was actually while I was at St. Dominic, because I went to St. Dominic High School, I managed to get a placement with Natasha Carty at the druggist in Simpson Bay, and she's the one that showed me what a pharmacist actually does. So after spending some time with her and working there for a while, I said, actually, yeah, I had an idea that this is what I wanted, but working with her and seeing everything that she did actually kind of pushed me in the end to pursue this as a career. So that's how I became inspired, I would say, to take on pharmacy. And now I'm colleagues with Natasha because I get to see her at pharmacy association meetings and everything. I'm not sure if I ever told her she was one of the reasons I became a pharmacist, but I'm sure she knows that. And yeah, that's how I got into pharmacy.
Any questions?
I have a question.
Yes.
You don't have to finish medical school to become a pharmacist, do you? It's a separate study altogether, isn't it?
So in the US and in some other countries, there's a lot of different fields that a lot of different pathways that you can take.
Okay.
So in the US, you can do stuff like biomedical sciences or biology, chemistry, pre-med even if you want as a bachelor's. And then afterwards you do a PharmD, so you become a doctor of pharmacy. So it's actually after your bachelor's, you go on to do pharmacy school, the same way that you would do medical school. So you can decide a lot later in your university study what you want to do. In the UK, you have to decide right away after you finish your kind of VWO level or IB, as like they have at St. Dominic. Yeah. You have to decide right away whether you want to become a pharmacist, a doctor, or a nurse. Like you go straight to that stream. You don't have a choice of deciding later. Some schools, what they've done in the UK is they have a foundation year. So they put everyone, doctors, nurses, pharmacists, in the same year at the beginning. Mm-hmm. And then midway through the first year, they ask you, or they haven't told you that they've put you all in the same class. You find out when you end up there because you've decided to choose pharmacy or medicine or nursing. But they know that although you choose the course, you may not be suitable for it. And then midway, they ask you, okay, you chose medicine, but after the first 6 months, do you really still want to be a doctor? Because right now, you still have the option of changing and becoming a nurse or a pharmacist, whatever. Mm-hmm. So there's a little bit of flexibility, but not much. You do 4 years in the UK, and then you do, once you graduate as you get a master's in pharmacy. They don't do a bachelor's because you cannot practice with a bachelor's degree, an integrated master's degree. So once you get your master's degree, you have to apply for a placement at a training place, which can be a normal pharmacy or a hospital. And what you have to then fulfill is a portfolio of competencies to say that I can complete this, I'm competent at that, with your supervisor. And then at the end of the year, they say whether they think you'll be a good pharmacist or not. Their opinion actually matters quite a lot. And they say whether you should be able or allowed to sit a registration exam, which is an exam, usually multiple choice, in 2 parts, which tests your clinical knowledge, your legal knowledge, because a lot of pharmacy is actually law.
Yeah.
They take into account ethical situations, decision making, and a big part of it is calculations. Mm-hmm. If you don't, for example, the passing rate for the exam, I think is 70%, but if you don't get a 90% in the calculation section, you fail. So because a lot of pharmacy is also calculating doses, so mathematics is very important.
Yeah.
That's how after you pass the registration exam, you wait a couple of weeks, and then they tell you whether you can register as a pharmacist or not. Yeah. And I think it's the same in most countries. You do a period of training, and then you do an exam.
It's quite similar to almost like an apprenticeship as well, eh? But then like at a really high level.
It is very similar to an apprenticeship, because when you come out of pharmacy, you know nothing. you know the basics, you know the fundamentals about science, you know about body systems, you know the basics about drugs, but you don't really get a lot of kind of knowledge about how to approach patients, for example. They do a little bit of it in school, but it's when like a large part of your competency is how you interact with patients.
Okay.
So you will be supervised, and your manager or your supervisor will actually put you in situations, and they will monitor you and mark you on it while you're doing your year of training.
Hmm. Interesting. Cookie.
Yeah. Hi, Sophie.
Hi.
I would like to know the big difference in the brand medicine and the generic medicine. Is it really bad that we cannot have generic medicine of all sorts?
You mean brand medicine? They're giving you generic most of the time.
Yeah. So the difference between the branded medicines and the generic medicines is only a license.
Yep.
When I say that, I mean a drug company has invested sometimes 10, 15, 20 years developing a drug. Because they've spent so long, it can be shorter, but because many companies spend so long investing in the development of a drug, they then have to apply for a license to be able to market the drug and sell the drug. What a lot of regulatory bodies do, like the FDA, is they grant you a license for a certain number of years. And what that license basically does is allows the drug company to recoup all the money that they've lost while developing the drug.
Right.
So if a company, for example, like Pfizer said, I spent 5 years developing this drug, but you know what? I will give up my marketing authorization and I don't care about having a license. Then they can give the formula to anybody and make that drug. So the whole thing against versus like branded versus generics is simply licensing.
So it is no harm in taking the generic medication as such.
There's no harm at all. For example, a lot of branded companies like Pfizer actually also have a company that makes generics for them. So Pfizer, for example, makes a drug called Lyrica. And when Lyrica lost its license, and I experienced this firsthand, Lyrica lost its license. The license had expired, so it went to generic, and they changed the box into pregabalin. And when I opened the box, the back of the foil on the back of the tablet still said Lyrica.
Yeah.
Because the generic company Teva belongs to Pfizer. So it's half of the time there is no difference at all. It only really matters if you get branded in generics for certain drugs that changing the formulation. So changing the type of powder or the type of additive to the tablet. It's only important in certain conditions where it changes the way the body absorbs it. For example, transplant medicines, you should always prescribe according to the brand, because taking one brand, say Prograf, would be different from taking a generic, the way that your body absorbs it. But at the end of the day, you still get the same result, but you don't want to play around with it because different patients might react differently. And I think there's only, off the top of my head, 6 or 7 drugs where prescribing by brand is actually important. Everything else, it doesn't matter. And they've done, when they say this, it means that they've done studies to actually see the difference between the brand and the generic.
Okay, on personal level, I'll give you a call on my medication. But the other things I would like to know is when you go to a pharmacy, like I might be a fortunate one, I give them Najiko card and I give them my SVB card, SZB card. And they give us different medication depending on which card they use.
Yeah.
That is correct.
That has become a new practice, and I don't know why. Especially in my case, I've been taking hypertension medication from last 15 years, and every time the brand is like, for 4 months I'll get the same brand, And after that, oh no, we can't give you on this. Oh no, we can give you on this. Suppose if I give them only one card and I don't get the other one, which I'm always getting, I sometimes take the picture and show them that last month you gave me this, but why not this month? So this is really, I know might be the core elements involved in medication are pretty much the same, but it's playing on your mind that, oh shit, I got a different name now. I don't know if this will have a side effect on me. So
I'll tell you why that is. It's all about money.
Mm-hmm.
I
Okay.
know.
Okay.
It's all about money.
Okay.
I really want to see if you that enough strong that I can liaison with you to break this kind of nonsense happening. I would not say in only St. Martin. This is all big money play by many others in many countries. But for our people here, we can try to break this up. And I'll give you a personal call to see if we can team up and break this ice.
So I'll be honest. I will always aim to give the cheapest of the drug that I can find.
Yeah.
Because for me, buying and supplying a branded drug is a waste of money.
Mm-hmm.
And at the end of the day, it's not money lost from my pocket. It's money lost from the insurance companies. Or in the case of SZV, the taxpayer's pocket.
Mm-hmm.
Because at the end of the day, I only make a certain amount. I don't make a percentage. I make a fixed rate on every prescription that I dispense. If a drug costs 2 guilders versus if a drug costs 20 guilders, that 20 guilder cost is going to SZV. I still get my fixed markup. If I can charge SZV 2 guilders, that's an 18 guilder cost that I've saved SZV. So that's an 18 guilder cost that I've saved the person paying SZV.
Mm-hmm.
So I will always endeavor to give the cheapest one. And I think where the problem comes between different insurances is that they all care about cost containment. SZV care more about their final line, so they will go for the cheapest possible, where Najiko's and Enya, like private insurances, their way of cost containment is different. So they will say that anything that you can buy over the counter, they will not pay for.
Yeah.
They have different ways of containing cost. So it all depends on the insurance company. I know that there's a lot of different rules, but at the end of the day, it's all about money. And I think that's also my standing in this is because I came from working in the NHS, which is the National Health Service, where everything is funded by the taxpayer. Everyone has the social health care. There's almost barely, I think it was something like 3% of the population has private health care. So at the end of the day, the more money that I could save the taxpayer, the better it was for the whole country.
Mm-hmm.
So, and that's also a major part of a pharmacist's role. So even situations like, if I give you this one drug for blood pressure, and a new drug comes out, I will look at the evidence and say, is that new drug actually better than the one that you're already on? Because I know that new drug will also be more expensive. If it's not better, why am I going to choose it? Because I'm just going to spend more money for something that's in fashion because it's new, whereas if you take it compared to the old one, it's not going to do anything different. So that's actually a large part of a pharmacist's role, is doing cost evaluations in terms of whether it's therapeutically efficient or not. So I will always challenge any doctor who tries to prescribe something new where something already exists and is working just fine. Whereas obviously if it does a lot of a better job, I will go with it. But a lot of pharmacy is actually thinking about money, which is not what a lot of people think. But yeah, it's a lot of my job.
Yeah.
My final question, I know of India that I can speak about, that we have seen in my childhood days, a lot of medical reps going to the doctors to prescribe their products. Does that happen in St. Martin too?
Yes.
In St. Martin, it does happen. But what I will say is that St. Martin, the old regulations, there's new regulations coming this year. The old regulations prohibited a lot of new drugs coming onto the market because of registration issues. So your drug had to be registered on the island to be sold on the island. And if a rep just came with a new drug, like, here, prescribe it, I would be like, oh, that's great, but I can't get it because it's not registered. So really, it's kind of pointless for reps coming around. And actually, from my experience at Cahill Pharmacy, we entertain them and we say, okay, what are the options? But it doesn't mean that you're gonna get us to push the prescriptions to come through. Or
yeah, so at least there's a
evidence.
fair market in there.
Yeah. So but we will always check for the evidence. It's not about it being new and amazing. It's, okay, where is its position in the treatment, and is it better than what already exists? A pharmacist will always do that, and they will always challenge the doctor who's been approached by a rep. You always get doctors prescribing new things like, oh yeah, the rep came the other day and said this is amazing, and I'm like, it's not that amazing. It depends, but yeah, we will challenge it, because obviously if it's not going to do any better, then why are we going to go through all the stress of procurement, stocking, trying to get it approved? There's a lot of administration that comes with it, and especially if it doesn't do anything better, then what's the point?
Okay, my final question. Sorry, I said before last, but one more question I recollected. When you get a prescription from a doctor and he prescribes you a medication for 6 months, like you have to take this for 6 months, and you go to a pharmacy, say now it's January, and he gives you the medication, and when you look into the boxes, might be after you get home, that the box says April 2021 expiry. Is it liable that the pharmacy should change that and give an extended expiry, or is it a base that he might know, I gave you currently now and it's not expired, so you have to take it?
That is a kind of a practice decision. It's unethical to give expired medication that you know will not be used beyond the expiration date. So if you came and pick up 6 months supply, and I gave you 6 months, but it will expire by 3 months.
In
then
4 months it will expire. So the next 2 months,
yeah,
I'll be
that's
taking
not good
expired
practice.
medication.
Yeah, that's not good practice. What we should do is do something like give you a 3-month supply of this medicine that will expire in April, and then try to procure a longer expiration date medicine to supply you for the rest of that duration, and indicate to you that you should use the one that's going to expire first, and save the one with the longer expiry to use later, because you don't want it ending up expired in your hands either. So
suppose even by mistake, suppose I did not notice the expiry and I take it, is it really going to be anything bad? Because what I heard is, even if you take an expired medication, say after 6 months, the effect is only diminished by 2 or 3%. 97 to 98% it's effective. Is that true statement by someone?
It depends completely on the medication. Because
so
what
there
you
are
do
medications that if it says April 21 and it'll expire, means they are really bad after April?
Yeah, there are some medications that, especially, I would say, for example, some liquid medications that you take orally, someone's done this formulation and they have, for example, it's a sugar-based syrup that they've done all the research and they know that after a week that they've made it, it's not going to be good anymore. But for example, another good example of where expiry can be extended is EpiPens, you know, for when you have a bad, serious allergic reaction.
Yeah.
There was a situation a couple years ago, or 3-4 years ago, where there was a worldwide shortage. And what the company actually did was they went back through all their data, because they do something called expiration studies, or stability studies, which is how they come up with this expiration date on the tablets. And they did extended study where they had stuff, say, expiring on April 2020, And they continued doing the study, and they realized actually it's pretty stable until April 2021. So then they issued a worldwide statement saying anyone with these expired pens can continue using them until this extended date, because it's better to have something that they've retrospectively analyzed and said is stable than to have none at all. So there has been situations, for example, if I keep something out of the fridge, like an insulin that's supposed to go in the fridge, and say it says store in fridge, but I forgot to keep it to put it in the fridge, and it's been out of the fridge for 24 hours. There are situations where I can call the drug company and say, look, I kept it out of the fridge for 24 hours. Do you have any extended stability data that can tell me what I can do with it? And they might actually reply and say, okay, you have to adjust the expiration date to 6 weeks from today, because today is when you realize that you took it out of the fridge for more than 24 hours. So they have that kind of data, but they cannot necessarily, for them to be more safe than sorry, they have to stick to what is scientifically proven.
Okay.
Thank you.
Thank
So
you.
Glenda, Glenda, your question, please. Cookie, the
Marcy,
next, you have to call.
Marcy actually was a cabinet question for a while now.
Okay.
Yeah, but Cookie just held
Sucked
on.
up. Is it fair to all concerned, Cookie?
Like, but my questions are short and concise.
Listen, I
Cookie,
kept
can I get a
monitoring
dig
the
in?
participant list. I didn't see any raised hands. So I was thinking it
Impossible.
was only
I've
me.
been trying.
Yes, she has.
So my simple questions were very, one, can you all be held liable for recommending something to someone, you know, that they didn't have a prescription for, and then the person gets ill and they're like, it's you that told me to take that. Can you all be held liable? That's one. Creative promises.
So
Here on St. Martin.
I don't know about here on St. Martin. I know in the UK, everyone who is practicing is recommended to have liability insurance, like professional liability insurance for any decisions that are made during your job time. So if I am on the street and I recommend something to you, it's not liable. But if I am in the pharmacy and you ask me as a pharmacist and I recommend something and it does something harmful to you, then I am liable. But what you have are different types of liability. So you can be covered by the liability of your workplace. So usually they have a group coverage, or you can also have an independent coverage. So you can pay separately for your own coverage to protect yourself. In St. Martin, I am covered by the pharmacy's liability. But it's also, there's a clause in this liability where it says that if I have recommended to someone something that goes against the policy of the workplace or the recommendations of the workplace, so the advice that I've given is not in line with standard practice, then the pharmacy can say that she did it on her own, therefore our liability insurance will not cover any damage that results from her decision making. In which case I would be fully responsible. I have not heard of any situations on the island where that has happened. I have had situations in the UK where, not for me personally, but I've heard about it happening, because in the UK it's a very open culture about when errors happen. In St. Martin, it's not. In St. Martin, I will admit, just because I think I trained and I practiced in the UK, if I make a mistake, I will openly admit that I made the mistake. Because the concern is that you denying that you've made a mistake is actually worse than having the mistake done in the first place.
Okay.
But in the UK, it's very much an open culture that if you've done something wrong, you admit that you've done something wrong. And the fact that you've admitted it and you've learned from that mistake allows for a less harsh kind of punishment.
Okay.
So everyone kind of understands that, and everyone knows that you have to learn from errors in the UK. So they actually publish a lot of these kind of situations in the UK. and they let it known to people so that they can avoid these kind of situations. But here I will say honestly that from my experience, I've noticed, not in my pharmacy, but hearing other stories, that a lot of the time if someone does something wrong, they won't admit to that they've done something wrong, and then it causes the necessary.
Claudia.
Claudia.
Yeah, I just
And the last question I had, natural remedies. Do you recommend?
Did you hear that? Because I was mute.
Yeah, we
yeah,
heard the point of that nose.
actually I
Oh,
put
yeah.
you on mute for a second because I was like screeching.
Yeah, sorry, what was your natural remedies?
Was natural remedies. You know, persons are into using natural remedies instead of using tablets.
So,
Do you
so
recommend?
it's a very fine line for any pharmacist when you talk about natural remedies, because for every pharmacist, a part of your education will always be about natural remedies. So I had a whole module on traditional Chinese medicine and how you derive the medicines from plants and so forth. And I had a very passionate professor who was all about plants. But you also you appreciate that a lot of drugs come from plants, but you also appreciate that because plants are unrefined, meaning that depending on the conditions that they are grown, depending on the species that you might have, depending on the conditions that they are kept, that the effects that you might want from the plant might not be the same every time you take it.
Okay.
And because a lot of studies are not done on plants, sometimes you can actually do more harm than good.
Okay.
So, yeah, so it's
Up to you, Sophie. So if I were to come up to you and I would say sleeping tablet versus some soursop leaves.
I would say it's a situation where you can always say that the decision is always yours, that it's probably okay in moderation. But if you want to fully go into that field where you say, I will not take any sleeping tablets and this I will take every night and I will religiously just do only this. And I know that, for example, for some drugs, I know that for some plants, I know that they would interact with some drugs. And I know, say, for example, you're on blood pressure tablets, that it might not be good for you. That I will say, okay, once in a while is all right, but I wouldn't recommend it every night.
Okay.
So it depends completely on the plant, and it depends on whether you have other conditions or not. That's what I would say. It's always an assessment of the current situation.
Okay, thank you so much, Sophie. That's it for me.
Last question, Glenda, because it's quite late.
Good evening, everyone, again. So, Sophie, seeing that you're a pharmacist, you know the big question that's going around now. I was even asked the question, would you take the vaccine when it's ready or when it's available? So, I just want to know what's your intake, because I hear this one is good, this one is not good, this one has side effects. Some people decide they will never take it. Some are waiting to take it. So what's your intake on that?
So I've had a lot of discussion because I'm also doing a master's, an executive master's with healthcare professionals from all over the world, and this was actually posted in our WhatsApp chat over the past 2 days. And I'm getting a lot of responses from different people from like different parts of the world, Canada, Dubai, Australia. Everyone has an opinion, which also gives you an opportunity to form your own opinion. And I say that it's an amazing advancement, these new COVID vaccines. I'm all for vaccination in the first place. I'm not against vaccination. I think vaccination is a necessary thing. For the COVID vaccines, I think if you are someone who is kind of, just because of me, patient facing, where you have the risk of coming into contact with someone who might have COVID. So imagine if I was a cashier at a place, or I had a store, or someone who takes care of someone elderly, which a lot of us take care of someone elderly, and you are concerned, I would say vaccination is necessary. If you are someone that stays home all the time, you don't interact with people, and you do have concerns, I'm not saying don't get vaccinated, but you could probably wait a little longer to see what goes on. Personally, myself, just because I am a young woman who's in a childbearing age, I would rather, for my reproductive state, because I have not had children yet, I would probably wait a little longer for me personally, because I want to see if there's any data that emerges on women who are pregnant or are looking to become pregnant, which is because they don't do clinical trials on women who are pregnant. But if the traditional vaccine, like the AstraZeneca one, comes out tomorrow in St. Martin, I will take the traditional vaccine. Just because the Pfizer one and the Moderna one are new technologies, and they've tested it in a lot of other populations, but not pregnant women. So it's all depending on your situation. For example, I would recommend that my mother and my father get it right away, just because I am a healthcare professional and I would want them to be protected. But for me and the potential of me having a child in the near future, I don't know how the new technologies are going to react. I'd rather wait for a traditional one, which is around the corner. It's been authorized in the UK already, and I will have that one. So it's all about everyone's individual preferences. But I'm all for vaccination. I would expect most, or if not all, of the island to get vaccinated as soon as possible with whatever we get. It's necessary to protect everyone and to stop this pandemic.
I heard about the traditional, the fact that these new vaccines might cause infertility in, teens and persons in their 20s and 30s. So I've heard that too. You mentioned traditional vaccine. So is there a difference in between the two vaccines from Moderna and Pfizer?
The new Pfizer and Moderna vaccines use a new technology that, although they've been researching for almost 20 years, it's the first time that it's being put into practice. So they have a lot of data, but they don't have data on pregnant women, because you never test in pregnant women. That's like one of the #1 lines. You don't test in children and you don't test in pregnant women because it's unethical. Because you will never know. It's not about causing infertility, it's that you don't know what it will do to a developing fetus.
Yes, that's what I've heard. But at the same time, you said this is a new technology. So
yes.
I know for a vaccine, it takes years to produce, but all of a sudden they have vaccines for COVID, which I don't get.
Well, it's similar to the way that they had remdesivir just off the shelf. Just because it's come out quickly doesn't mean that it wasn't something that was already waiting on the shelves.
Right.
So they had a lot of different research about different types of corona, because corona is a big group of virus. COVID is specifically one strain of a corona. So they have a lot of research about corona viruses in general, and all you have to do really is tweak it to what you know about the current strain. So it's the same, it's similar to what they do with flu vaccines. They make a flu vaccine every year because they have data on a whole range of flu vaccines. So for them to come out with a different vaccine next year is not a lot of research. They just have to tweak what they know about the last ones and what they know about the current one to make sure that it works for the current one. So that's kind of and as I said, they did the research for almost 20 years on this new technology, but it doesn't mean that they didn't also have information about coronaviruses. So they've just kind of merged new technology with what we know already about coronaviruses that we've been doing research, put them together, and come up with something, test it, and make sure that it's okay. Just not in pregnant women and children, because that's unethical.
So next year they might have a new vaccine for the new strain.
It's possible. It's
like
possible.
the flu.
We don't know that much about COVID. It might be like flu. I attended a lecture, an online lecture about this the other day. For example, chickenpox The same vaccine has been available for the past 30 years for chickenpox. It will still, the strain hasn't changed that much in 30 years, whereas the flu vaccine changes every year. You don't know where the COVID virus stands in that big window. Is it more like the flu or is it more like chickenpox? We don't know yet. So it might change next year, or it might be the same vaccine for the next 20 years because COVID doesn't change. We don't know.
Thank you so much, Sophie. I mean, that was that was really, really good. And that was a vast conversation of topics.
Excuse me, Dolly, I'm just going to interject here just for a moment.
Yes.
I think President Alicia has asked a question to Sophie. She wants an answer regarding some pills. If Sophie can look at the chat, please. Just what she's asking is, can you name anything over-the-counter medicine which is close enough to sleeping pills?
The things that would be over the counter that are closest to sleeping pills would be a sedating antihistamine. So like in your NyQuil sleep time, there's an antihistamine in there. So the usual antihistamine that you take for congestion, for when you have hay fever, for example, there's some that make you really drowsy and there's some that are non-drowsy. If you want something that is close enough to a sleeping pill, you would take an antihistamine that makes you very drowsy. So those tend to be in things like NyQuil, or you can even ask your pharmacist if they have an antihistamine that you can buy over the counter that will make you very drowsy. So they will categorize that. Every pharmacist has to know the difference between a non-drowsy and a drowsy antihistamine. That's the closest thing I would usually recommend. That's why they use it in some cough syrups and so forth, because of the side effect of it making you drowsy. So it helps you to sleep. I think that's it. Yeah.
Thank you. Don't forget your happy dollars, everyone.
I'm still waiting to write from some of the members. Just waiting for them to.
I need to know how many happy dollars I owe, because I think I have an outstanding bill.
I will send it back in the group. I did send it in the group. I'll send it back. I have the Excel sheet with both the first quarter and the second quarter, because some people haven't even paid for the first quarter yet.
I think I paid the first quarter for sure.
Yes, Damali, you have paid first quarter. It's the second quarter you have to pay.
Yeah, okay.
Okay, guys, I'm going to go now to the upcoming events. I'm going to quickly go. Sophie, thank you very much. That was a very, very, very interesting conversation. We are very glad to have such different vocational Rotarians, because it gives you insight on everything that we cannot think of in our own lives. So thank you for that insight. I'm going to go to our upcoming events because it is 8:45.
Wow.
Yes. On 13th of January, which is next Wednesday, we have Rita Davis, who is going to be talking about consciousness expansion. Rita is Bernadette's sister, and this is like the natural way that she does it. She does also have Reiki healing, and she will talk about consciousness expansion. That's the topic, she said. On the 14th board, we have a meeting, which is next Thursday. January 20th, we have a vocational talk from the COVID-19 team at the hospital. And we will also give them an award for their outstanding performance during this very hard time. On the 27th, we have our past president, Virginia Allison, who will be talking about the COVID-19 vaccination. She actually reached out because she is doing it in her 70-30. And she said, I cannot leave my sunrisers out. So she approached us and I said, of course, we'll be so happy to have you. So on the 27th, she will be coming and talking to us about the COVID-19 vaccine. And at this point, I am going to open the floor if anybody has anything to say. Yes, Marcy.
It's just tomorrow, 1:30, Ruby La Vega shopping. For those who are interested, I'll be at Costulas. Anyone interested in joining me to take a nice photo op? I know Peter said he might be joining me. Anyone else? Feel free. I am awaiting response from the other schools when we will be going shopping. That would be PWAS. I still haven't have a date from PWAS or Martin Luther King. So as soon as I know from those schools when they want to go shopping, I'll let the membership know. Okay?
Thank you so much, Marcy. Anyone else?
No.